An AI reads a routine ECG and flags hidden structural heart disease more often than a panel of 13 cardiologists reading the same tracings. This week, the FDA agreed it was ready, clearing it as one of the first multi-condition cardiology AIs of its kind. But a cheap test that uncovers hidden disease only helps if someone acts on the flag. That gap between what a model can detect and what we actually do about it runs through everything this week. Welcome to This Week in Healthcare and AI, the show that takes the most important new developments in medical AI and asks one question: does this actually change what we do for patients? This is AI in Healthcare. It's Saturday, the 27th of June, 2026. This week, an AI that reads structural heart disease off a standard ECG and earns FDA clearance, a reality check on ambient documentation and where its value really lands, a sobering new paper on patient privacy, what this week's evidence from PubMed does and doesn't prove, and a payment story that quietly shapes who gets AI-assisted care. Let's get into it. First, the week's headline clearance. A tool called EchoNext reads a standard 12-lead ECG and flags 6 forms of structural heart disease, things like heart failure from cardiomyopathy, valve disease, pulmonary hypertension, and severe thickening of the heart muscle. Developed at New York Presbyterian and Columbia, and commercialized by a spin-out called Pathway Labs, it became on the 23rd of June among the first multi-condition cardiology AIs to win FDA clearance. The case behind it is striking. In the validation study published last year in Nature, the model was trained on more than 700,000 ECG and echocardiogram pairs. In a head-to-head on 3,200 ECGs, it correctly identified 77% of structural heart problems against 64% for 13 cardiologists reading the same tracings. And this week, the company also announced it would put the tool inside Open Evidence, the clinical search platform used by a large share of US doctors. So does this change practice? Here's the honest read. EchoNext is a screening and triage tool, not a diagnosis. Its job is to tell you who needs an echocardiogram, and the echo still makes the call. Judge it the way we judge everything on this show. Compared with what? Compared with today, where structural heart disease often goes unnoticed until a patient is symptomatic, a cheap, ubiquitous ECG that quietly points to who needs an ultrasound is genuinely useful, especially where access to cardiology is thin. The cautions are equally real. A flag is not a diagnosis. False positives can flood echo labs and worry patients, and we still need prospective outcome data showing that finding disease earlier this way actually helps people live longer or better. So let it sharpen your triage, not replace your judgment, and keep the confirmatory test firmly in the loop. Story 2. A reality check on Ambient AI. Ambient documentation, the AI scribe that listens and drafts your note, is still one of clinical AI's most widely adopted tools, and the recent evidence is finally letting us separate the hype from the value. The good news is real. In a study of more than 260 clinicians across 6 health systems, published in JAMA Network Open, burnout fell from roughly 52% to 39% after just 30 days with an ambient scribe, with less after-hours documentation and more attention on the patient. But the productivity story is more nuanced than the marketing. On average, the time savings are modest, and they concentrate in heavy users. Only a minority of clinicians who adopt these tools actually use them for most of their visits. And the value is steadily shifting from the note itself into the revenue cycle around it, into coding, billing, and prior authorization. The lesson holds: these tools can give you back attention and ease the burden, but the gains depend on how and how much you actually use them, and you still sign the note, so you still own it. Story 3. The Skeptic's Corner, and this week it comes with a warning. A new paper in Nature audited the privacy of medical AI models and found something uncomfortable. Using what are called membership inference attacks, essentially asking a model whether a particular person's data was used to train it, the authors showed that for individual patients, the attack can succeed almost perfectly, even when the model looks completely safe by the usual aggregate privacy metrics. 2 findings should stay with you. The risk grows as models get bigger and more capable, and it falls hardest on the people already underserved, patients in underrepresented groups by disease, race, insurance, or even imaging protocol, were the easiest to single out. So, when a vendor tells you a model is privacy-preserving on average, ask the harder question: privacy-preserving for whom? Average safety can hide individual exposure, and the patients most at risk are often the ones with the least margin. Now, from the literature, straight from PubMed. Some weeks bring a practice-changing trial. This week, the honest signal was quieter and worth understanding. 2 large evidence syntheses landed, both on AI reading scans. The first, in European Radiology, pooled 41 studies of deep learning and radiomics models predicting whether breast cancer has spread to the axillary lymph nodes. On paper, the numbers look good. A pooled sensitivity around 0.8 and an area under the curve of 0.84. But look closer. A positive likelihood ratio of 3 and a negative likelihood ratio of 0.33 mean the model on its own cannot safely replace a sentinel node biopsy. The author's verdict: useful as an adjunct, not a standalone. The second, in molecular imaging, pooled 38 studies using MRI to predict which rectal cancers had completely responded to chemoradiotherapy, with similar discrimination and the same caveat: limited prospective validation. The through line is the discipline of this show. A strong area under the curve is a promise, not proof. Likelihood ratios tell you whether a tool actually changes a decision. And until these models are tested prospectively, they assist the radiologist, they don't replace the biopsy. With thanks, as always, to PubMed and the National Library of Medicine. Story 4. Follow the money, because payment quietly decides who gets these tools. A new analysis in the American Journal of Neuroradiology looked at how AI for detecting large vessel strokes actually spread once Medicare began paying for it through a mechanism called the New Technology Add-on Payment. Across more than 2,000 stroke admissions at over 1,000 hospitals, billed use of the AI climbed to about 21% by 2022. But here's the catch: who got it tracked? The hospital, not the patient. Use was about 6 times higher at the peak, and markedly higher at large comprehensive stroke centers and in the stroke belt of the American South, while no real differences showed up by patient demographics or stroke severity. In other words, reimbursement drives adoption, but it drives it unevenly, and that becomes an equity problem. The same AI that speeds care at a well-resourced center may simply never switch on at the smaller hospital down the road. Pay attention to the codes because they decide the map of who benefits. And the teaching point, the habit that ties this week together: before you let any AI tool change a decision, run it past 4 quick questions. 1. Compared with what? Against today's real-world care, not against perfection. 2. Is this a screening flag or a diagnosis, and what confirms it? 3. Does the number that impressed you, the accuracy, the area under the curve, actually change a decision, or just describe the data? And 4. Who does it work worst for, and what happens to them? A metric is a promise, a likelihood ratio, a confirmatory test, and a fairness check are how you find out if the promise is kept. So, the week in 4 lines. 1. Diagnostic AI keeps maturing. EchoNext can now flag hidden heart disease from a routine ECG, but it triages, it doesn't diagnose. 2. Ambient AI eases burnout and is real, yet its value depends on how you use it and is shifting into the revenue cycle. 3. Privacy is not solved. Average safety can still expose individual patients, and the most vulnerable most of all. 4. Payment shapes access, and right now it shapes it unevenly. What I'm watching next: prospective outcome data for ECG-based screening, the first audits of ambient AI inside billing and prior auth, and whether anyone builds privacy protection that actually protects the patients most at risk. That's this week in healthcare and AI. If one of these stories changed how you think, share it with a colleague who's practicing without the time to read these papers. New episodes every Saturday night. Subscribe, rate the show, and send your feedback and disagreements. Listener mail makes this better. This has been AI in Healthcare. Until next Saturday.